important people and what's actually preventing sensitive health data from being more open. And as this is a workshop, there will be some participation at the end through Menti, but I'll prompt you before we get started on that. So I'm very much preaching to the choir here, but why is this important? Hopefully everybody knows what FAIR is and why it's important to manage your data well and make it fair, not just to accelerate research, but make collaboration easier and, all importantly, facilitate data reuse. This data reuse is especially important with health data because a lot of our data comes from patients themselves. And if we're repeatedly asking patients to give us the same medical data over and over again, that's not a great use of our time and resources, and it's quite a big burden on them as well. And the European Commission has obviously estimated there's a massive cost to not having fair data in Europe to be minimum of 10 billion a year and a potential massive 16 billion a year impact on innovation. And this report was even written in 2018, so those figures are probably a bit lower than they are now. And obviously this is all part of strategic priorities, not just for funders like UKRI and Wellcome, also for institutions like at Manchester, for example, we have a dedicated office for open research, but also the G7 made a declaration back in 2024 entirely around open research. So it's very high up on the agenda. So in theory, we've obviously got the priorities there. We have a lot of tools to help us manage data and reuse it and that kind of thing. In theory, we have the infrastructure around it. We do have things like TREs and SDEs set up. And in theory, we've got the resources to help people learn those skills. But we're not quite effectively using these, I think it's quite fair to say. So what is actually preventing sensitive health data from being more open? And if we look at data and sensitive data, we've obviously got legal restrictions, especially with health data. And some of these can be kind of vague, especially in how you apply them in a technical capacity. And a lot of people struggle. It's very different reading a guideline to applying it to the data set in front of you. And there is a bit of a lack of guidance for that. More social issues, especially things like risk aversion. When data sharing goes wrong, there are quite big consequences. You know, we've got big fines from the Information Commissioner's Office. And there's not just consequences for people's careers, but it affects trust, especially with health data. If we are openly putting people's medical data online in error, that does quite severely affect the trust between patients and researchers. And then other social issues to do with our work environment, like these tasks aren't really recognised in terms of promotion criteria. And I know REF's improving its recognition of alternative outputs, but it's still much slower than journal articles. And poor adoption of these guidance and tools. If you've worked with health data, especially from the NHS, you know the metadata can be very hit and miss. I've personally had it as annotated PDFs, so it's not machine actionable. And I've worked on studies that are really odd that didn't have any structured metadata. So this all really affects the ability to reuse that data and make it fair. And if we look in the literature, Marta Anatol did a systematic review of looking at more restricted access data with FAIR, and they found that there's actually no FAIR framework that actually addresses the issues specifically for more confidential and restricted data. So while it's great we've got all these resources for FAIR out there, they're not always drilling down into the extra needs that sensitive data has. So I was awarded an Open Research Fellowship to look at researchers who work with sensitive health data, to really look at what do they actually know about RDM and FAIR, how much they understand about it, also what their current practices are. But the more interesting bit is their perceived incentives and barriers, because like I've said, we've obviously got the tools and infrastructure, but if people are experiencing barriers to using it, are they perceived barriers in that there's this fear of using it wrong, or is it structural barriers like they don't have the resources and time to actually use those tools? So the first thing we did for this was conduct interviews with researchers and project managers in my department. As interviews can be very rich data, we kept the group small and focused it in the department I work in. And we included project managers, as often a lot of professional services staff in health also are hands-on with the data, not just the researchers. And these were semi-structured interviews. So that means that we did have a set of questions, but we can ask for more clarity based on what the interviewees have responded and kind of follow that there. So we had a spread of interviewees across different career levels to really capture those different perspectives up the career path, all the way from PhD student up to professor. And when I asked most of them had not heard of FAIR, which is not surprising for a group of predominantly academics in a department that's very heavy on genetic and epidemiology analysis. A lot of the academics are also clinicians, they're not technical people. So this wasn't particularly surprising. And it was also great to see that they all agree that these things are important and that overall, even though there are quite a few barriers, they are still motivated to do good data management and try to make the data fair when they understand what that means. And when we drill down into the motivations for doing this, I mean, a big one was making trustworthy, high quality science, especially in terms of keeping and maintaining that trust with patients. Maximizing data use, again, a big emphasis on patients have put a lot of time into giving us this data, so we should respect that. And it's also more efficient to maximize the use of the data we already have. And future-proofing research, this isn't just so they can do more projects in future and collaborate with other people, but also when like PhD students and postdocs leave and you lose access to the data because it's not stored in a sensible place, or it's stored in an unstructured way that makes it difficult to work with. And then when we looked at limitations, the big one coming up was limited time and resources. Again, a lot of the interviewees weren't just academics with teaching responsibilities, but also they work in the NHS, so they're spending half their time as practicing doctors. So the time is really limited. Knowledge of best practice, again, these are not technical people, these are academic clinicians, so they don't have a lot of training around data management and FAIR. Limited infrastructure, this was particularly coming up when they wanted to combine different data types like omics and clinical data. If they're stored in different places, getting that infrastructure to talk to each other and bring that together is quite hard. And then the lack of human technical support, that is skilled people with really in-depth knowledge of RDM and FAIR who can support this work. And then obviously for health data, there's so much legal and ethical requirements around it. They're very well needed. Obviously, we need to respect patient privacy, but figuring out how to navigate all of that requires a lot of people, time and resources. And 4 out of the 9 interviews I mentioned actually spoke about dropping research ideas and collaborations because of the thought of the amount of time it would take to go around this red tape and figure out how they can collaborate and share data with other academics. One thing I also asked them was how could Manchester better support RDM, FAIR and data sharing? Key things coming up included more investment into infrastructure and resources, which also included training on how to use these things and apply it to their work specifically instead of generic training. More trained professionals to support this work. Recognition for these tasks and promotion criteria and across the whole. Improving connectivity between the related departments, for example, information governance and IT. There's a lot of confusion about where you go to get different information at different parts of the data lifecycle and where the guides are stored. So clearer guidance as well, and also examples of best practice, as it's a lot easier to follow that than it is to try and figure out how a standardized guide applies to you. This came up with the early career researchers as having a safer space to seek advice around these things and also ask questions. There was one early career researcher in particular who spoke about, especially being new to the role, it's quite scary to say to a professor, I don't know how to do this. Can you help me? So making sure that there is a place for people to come and ask the questions they may be a bit scared to ask and give them that support. And here's some of the quotes that came out. Governance and research are completely disconnected, looks like a lack of trust from the researcher's perspective, and there needs to be a better balance between protection and managing risk and allowing access to the data. Another person said that we just don't have the people to do this, and that's the main thing across the board. And again, from an early career researchers, they're just learning from mistakes, which is not ideal when it comes to sensitive health data. So we obviously wanted to see, are these just the perspectives in the centre I work in, or do more people experience the same things, or do they experience something different? So we put together a survey, and the questions were based on what we asked in interviews, but also existing literature that had looked at RDM and data sharing practices in health. This was set around various professional networks, mailing lists, social media, and targeted emails because we were struggling to recruit people to fill in the survey. We got 36 full responses in total. Most of them this time had heard of FAIR, which I think is a reflection of the networks they went around, which, like Elixir and HDR UK, are much more data infrastructure heavy. And most of the respondents were from the UK, but we did have quite a few from across Europe, and we even had a couple from Africa, which is quite nice to see that diversity in there. So if we look at the motivations, why they want to manage their data well, why they want to make their data fair, and why they want to share their data. So these are the top 3 reasons. And then the end column is how many people ticked this as an option. So across the board, things like good scientific practice and reproducibility came up a lot, and fostering openness, maximizing that benefit from data and preventing losing it. And yeah, mandated by funder, publisher, and institution also came up. And if we look at what the motivations that came up in the interview, again, very, very similar. So it was good to see that the survey is confirming that the viewpoints in the interviews are experienced by other people outside of my centre. And then we asked them about limitations. So before we gave them lists of limitations, we asked them if they experienced any limitations, yes or no, for RDM, fair and data sharing. So these are the number of respondents who said they didn't experience any. More people said they experienced no fair limitations, which I thought was interesting, but we didn't ask why, which maybe we should have. And again, we've categorized this into RDM limitations, fair limitations, and data sharing limitations. The numbers are lower again because quite a lot of people said they had no limitations. And if we compare them to the interview ones, things like time and resources are coming up in all 3 columns. Infrastructure is a bit less there, but knowledge of best practice is as well, and lack of human technical support. But the big one is, again, this complexity of the governance and ethics around this data, and also the patient consent hasn't been given for sharing. And this came up a lot more in data sharing, but even in the data management side of things. So we also gave an option for them to say other limitations that weren't included in the list, which was a free text answer. So for RDM, some of the free text were around the themes of there wasn't any real support for RDM where they work. There's a lack of space for physical data. There's still quite a lot of paper data collection in health going on. Legacy data is in multiple locations, and again, around infrastructure, the logistics of working in silos, which are necessary for data privacy. But if you think of trying to get 2 different TREs to communicate with each other, it can be quite difficult, and especially if you're not a technical professional, how to do that is really tricky. Senior staff not seeing the benefits of fair and data sharing also came up, and grant reviewers questioning the requests for RDM funding. And a specific example they gave was that they'd requested 2 full-time data managers, and the grant reviewers requested they slash that down to 1. So it was interesting that it's the grant reviewers requesting that, not the funders. And with FAIR, the additional work needed to prepare that data to be reused by external researchers who are interested in it. So again, some crossover with the interview limitations, which is confirming that the richer data we got in the interviews is experienced by others. We also asked if they've had particularly good or bad experiences with data sharing. Again, 10 people said they had no limitations. Quite a few people gave some examples of good data sharing, and some people said they'd had neither good nor bad experiences, which I take as a good sign. But as we're looking at why sensitive data isn't more open, I have focused on the negative responses here. One of them saying it was taking them years and years of contract negotiations to get to the point of sharing data, and when they'd actually finished, the teams had changed and they backed out. So it just completely killed the project after years and years of work. Someone received data that contained identifiable information when it shouldn't. 3 people said preparing data for sharing was incredibly time consuming, which didn't leave them with a lot of obvious gain or reward. And I remember one person in particular talking about how they'd spent a lot of time making the data open, but it wasn't cited or referenced in the final research publication. And then I thought this was quite an interesting point from someone where people who want access to their data for research, but they don't have the tools or knowledge to work with it and understand it to and analyze it properly. And then those frustrations are taken out on them, which I think is an important consideration. Maybe not everyone thinks about when sharing data. It's just put out there and then people can use it. But if people don't have the tools or knowledge to use it, then you might still have to work with those people to help them do that research. Also ask them how supportive their institution is towards data management and making data fair and sharing data. So 42% said their institution strongly supports, which is really great to see. We had 8% of people said that they don't know, and we asked them why. and they said it's not part of the promotion criteria, or they've just never had a discussion around the institutional views on these things. 14% of people were neutral, and again, some of the reasons why is the Institute's main activity is healthcare, not research, so sharing's not top priority, but they do try and prioritise good data management. And the person said there is little engagement in this kind of thing, though it's acknowledged, but it's in general something they feel they need to do. And 36% of people said somewhat support, so it suggests that there's something there, but it's not quite all the way. And a summary of it is that there seems to be quite strong verbal support from people's institutes, but then there's still a lot of difficulties around infrastructure and contacting information governance for further support in particular. So some of the quotes here that the institution supports the idea but doesn't provide the time and resources or value in promotion. And that another person said their institution lacks the infrastructure for good data storage and that they don't have competent people to help with making data fair. And as with the interviews, we asked what they think their institution should do to improve around supporting RDM, and I'll show slides later on fair and data sharing. And we also asked them in general about the systems in which they work, like the academic research system, what they think should be improved to better support RDM. So for institutional improvements, 6 people want simpler, more streamlined data and governance processes. Again, not surprising given how much the complexity of governance keeps coming up. A reduction in risk aversion also came up, very linked to the above. A lot of people wanted more knowledge and capacity, which includes training and tools around RDM. A lot of people also want more skilled professionals to help them with this kind of thing. An awareness of the confidentiality differences between the research data and the more operational data of their institution, and of course, recognition for doing these tasks. And then for the wider system improvements, a lot of the same suggestions as in the institutional improvements, so especially in terms of skilled professionals and knowledge and capacity and recognition. Changing journal expectations around what's provided. I think this was in reference to data sharing statements. I've written increase in skilled professionals again here because, interestingly, people highlighted the importance of a community for these skilled professionals and career pathways for these skilled professionals when talking about the system, when they didn't mention that in their institution. And 3 people spoke about that there. That the funders fund RDM more fully and maybe have stricter rules around following this up and making sure people are doing what's in the data management plans, and also reviewing grant reviewer attitudes to funding RDM. As I mentioned on the previous slide, some grant reviewers are slashing the cost of RDM when they maybe can consider not to. So we asked them again for fair. Again, we'll have some of the same things coming up, more streamlined, clear processes around how to make your data fair and where to go for information on this. Reduce risk aversion again. I think when it comes to sensitive health data, a lot of people here making it more open and interpret that as just putting people's medical data publicly available. So I think we also need to be really clear at what open sensitive data means in practice, and that it doesn't just mean putting everything online without restriction. Again, increasing knowledge and capacity around FAIR. A lot of people wanting an increase in skilled professionals to support this. Recognition again. And 3 people put more focus on FAIR in their institution, but especially a better understanding of why FAIR is important and it's needed, especially by the information governance teams, with the view that when they understand this, maybe they'll be a bit more open to working with the researchers and making the data fair whilst respecting the government's needs. Again, with the wider system improvements, same as the suggestions for institutional improvements. We had a few people suggest that making FAIR data should be mandatory for publication and funding, and figuring out ways to assess this. Better work environment came up, which is interesting. It suggests that they're not being supported in the wider academic landscape to do these tasks, which we've seen with points at recognition, but maybe just the overall academic emphasis on papers and grants over all these alternative outputs and tasks. A really important point from one of the survey respondents was increasing public trust in FAIR and open science. Again, if we're saying we should make health data open, we don't want the public to interpret that as we're just putting their NHS records in the internet. We want them to understand what that means, why it's important, and we do that with them, not just make those decisions on their behalf. And then we asked for data sharing. Again, more streamlined processes, reducing risk aversion, specifically in governance and contracts teams this time, increasing knowledge and capacity around data sharing, increase in skilled professionals, and quite a few people specified more legal professionals with knowledge of RDM and FAIR, who can understand both sides and figure out how that governance and legal requirements can be applied in a technical capacity. Better systems and tools to do data sharing. Again, we might have the internal infrastructures, but if we're thinking about multiple trusted research environments and doing some kind of federated analysis, or if you want to share data between one institution to another, do we have the systems and tools set up to do that really, really well? And again, recognition, system improvements, a lot came up as the same from institutional ones. A couple of people said mandatory data sharing if possible, the if possible being a clear part acknowledging that we can't share everything publicly. But mandatory data sharing statements for every publication, even though in theory we should be doing this, it's maybe not happening in practice. Clearer vocabulary in legislation, which ties in very well to that increase in skilled legal professionals. More established informed consents. We still have a lot of patients being consented to do medical research where they're not asked to consent for their data to be reused. And that can be a really key blocker to reusing and sharing that data in future. And an increasing willingness to share came up, which I thought was interesting as well. So this brings me on to my thoughts on what the core themes coming out of this are. The first one being privacy. Obviously, there's a lot of, I put it in quotes, red tape, very necessary red tape, but it does require a lot of people, time, and resources. And coming up in the surveys and interviews is that there is this disconnect between governance and research, which is making it harder to figure out how to navigate this red tape and make data more fair whilst respecting patient privacy. Also, the complexity of these processes, we heard in the interviews, people are stopping projects before they've started because it's so complex they don't want to get into it. Patient consent, like I just mentioned, if patients aren't consented to future data reuse, this is a really big blocker to using that data for anything else. And there are mechanisms to get around it, but trying to get in contact with patients is really time consuming, both for researchers and for them. And again, infrastructure logistics, importantly to maintain privacy, but this makes it more difficult to share. So figuring out how to do maybe more things like federated analysis, where you keep the separate infrastructure private, but you're still allowing that layer over the top to do analysis over multiple different infrastructure. Another core theme I think is coming out of this work is power, specifically that there is a lot of verbal support, especially around policies and strategy, but it's not equating to real life support for RDM, FAIR, and data sharing. So we heard a lot about staff feel they have very limited time and resources, especially for RDM and FAIR tasks. And if an institution's saying these are important, but not giving staff the time and the money, but also people with the skills to help them with this, then they're not really supporting that work. Again, infrastructure issues, getting it to work together and getting people with the skills to use it. Lack of recognition for these tasks. REF has got a bit better at this, but it's still prioritizing a lot of journal publications. So it is very clearly saying that the priority still is journal publications, even with this increase in alternative outputs. Senior staff who don't see the benefits. You might have an early career researcher who's really enthusiastic. They've done the right training to make their data fair and manage it really well. But if the person they work for doesn't see the benefits of doing it, they're not going to be able to spend their time doing RDM and FAIR. And having funding questioned by reviewers. When the conversations I've had with funders is they're very keen to fund more RDM. And I caught the end of the last presentation talking about that we do have this central funded data management structures like the UK Data Service. But if reviewers are questioning this in the in-between stage, then it's maybe blocking some of the resources. And then, yeah, like as mentioned, no safe spaces to ask. I put it in brackets, stupid questions, but they're not stupid questions. But for people who don't have this technical knowledge of how to manage data and make it fair and share it appropriately, it's really important. There is a place they can go for support and advice and to ask all the questions they need. And the other core theme I think comes out of this is around people. We can have complete respect for privacy and infrastructure set up to do that. We can have systems that support us doing RDM, FAIR, and data sharing, But if the people within those systems don't have the knowledge to do this, or they don't want to do it, it's not going to work. And if the system as it is really frustrating, which is resulting in more negative feelings around this. Again, we have a lack of skilled people, and not just skilled people, but the career paths for these kind of roles, like data stewards. A lack of training to upskill people, not just data stewards, but academics who want to improve their data management and FAIR skills. Again, this disconnect between data and governance and contracts. How much of that disconnect is because of the differences in governance and what we want to do with the data, and how much that disconnect is because of people not talking to each other. And then people taking out their frustrations on each other. We heard in the interviews that people are dropping collaborations before they started. There was the quote from the surveys where, because it took so many years to do the contracts, that they dropped the project when it got to the point where they could actually do stuff. So it is resulting in negative outcomes, unfortunately. And then there is obviously this understandable risk aversion to doing things. So yeah, it's a really difficult landscape for people to navigate, and that is leading to people being unwilling to share, which isn't surprising, given you've got a really complex landscape where there's not a lot of qualified people who can have dedicated time to help you. There's not dedicated training. It's really tricky for people to get to grips with this. So hopefully that sparks some interesting discussion. And obviously we need to look at how to overcome these barriers, because these aren't the kind of barriers you can just build a new tool for. A lot of them are cultural. And it does take a lot to create those wider spread cultural shifts in practice, and a reminder that there is no even just a simple FAIR framework looking at this. So this is the part where I wanted to do a call to action and get all of you to be a bit more involved. A lot of these barriers are quite big, like we can't overhaul single-handedly the publication system or how we fund research, but I genuinely believe there are small things all of us can do to help nudge us in the direction to make the environment more open to making sensitive health data more fair and open as well. So